My talk is going to be one about actually how we use data that's becoming more and more available in our routine consultation process. So as you heard from Pratik there, in the UK, we don't necessarily use quite as much technology as some of our cousins across the pond. But I think that what we still have to work hard on is this idea about how we use the information from the technology in order to help us make better decisions. Because although I think the future of closed loop therapy is clearly very bright from the perspective of people with type 1 diabetes, the reality at the moment in the UK and in actually large parts of the world is that less than 1% of people with type 1 diabetes are actually using closed loop in any format at the moment. So it's a case of optimizing what we have right now. And I think the other issue that we need to obviously be aware of is that the diabetes consultation can be a very busy place. We often don't have as much time as we'd like to spend, and we have what seems to be an ever-increasing agenda list of things to cover. And so obviously, in talking about that in a routine consultation, I'm only going to be really talking about this idea about the glucose management aspect of a consultation and the way we use information in that. And realistically, when we do a glucose consultation, we have to recognize that what we're trying to do is really to start with a very general view and then focus in over time. And so the tools that we've had historically have been quite reasonable from the perspective of looking at these overview tests in terms of an individual's average glucose, but really give us virtually no information. And I'm thinking obviously of the hemoglobin A1C here, give us virtually no information from the perspective of the range extremes in terms of how high might it go, how low might it go, and in particular obviously then the detail around that, which is the times of day that we might see those things and the times of day in which we might see risks related to glucose variability, for example. And so a lot of our consultations around glucose control will end up in trying to help problem solve, as it were, areas of difficulty. And the tools that we've had historically just haven't allowed us to do that. So as I say, hemoglobin A1C can do the first of those things. Potentially, if it's used carefully and used well, fingerstick testing can actually give us quite a lot of information about some of the other goals that we have within the glycemic consultation. But I think the power really here is that from a perspective of the continuous glucose monitoring devices, they can give us all of that information with one investigative tool. And so with that in mind, I guess it's not really that surprising that we've seen this dramatic growth in the use of CGM. This is almost certainly probably an out-of-date slide now because it's almost impossible to keep an in-date slide around CGM use, and I apologize that it's very UK focused. But I think the important thing, and what I wanted to highlight really from the point of view of this at the moment, is that in the UK and indeed worldwide at the moment, the vast majority of continuous glucose monitoring devices that are being used and sold are actually these so-called flash glucose monitoring devices. So the Freestyle Libre device, which actually at the present time accounts for around about 3/4 of all the CGM devices that are being used. And whilst in the UK we've been with work from people like Pratik actually pushing the ever increased use of this in people with type 1 diabetes, what we also have to recognize is that it's probably 40 to 50,000 people with type 2 diabetes in the UK using these as a self-purchase process, which may parallel the use much more around other parts of the world. Because of course, as I've highlighted, I think that the important thing here is that an individual's experience of the glucose is far more than just the average. And in particular, I think we need to start bearing into mind the variability measures. And in particular, I think we tend to classify those, don't we, in terms of variability within one day and variability between days. Because these variability measures, I think, have at least as much impact on an individual's quality of life and on their likelihood of developing complications from their diabetes as the average overall. So what we can see is that CGM data is a very powerful set of data. Because we can validate it, we have to use a computer realistically to analyze glucose data from CGM devices, because there's too much data for us to be able to look at columns of figures realistically. And because it's measuring all the time, it means that we don't have any bias in the way that that data is being collected. And of course, because we have that continuous measure, it will give us the information, all of the information that we might need to try and help make people to make better decisions around the therapy for their diabetes. Now, that's an awful lot of pluses, and realistically, I don't think there's any other tool that has given us that many pluses, but it comes sadly with a price. And the price is that analyzing glucose data that's so plentiful can be quite challenging. And if we look at the different devices, we could say, if we look at the Medtronic device, there'd be over 4,000 data points in a 2-week period. So it's clear that we have to look at this data from the perspective of projected images of that data, rather than just looking at the numbers, as it were. The difficulty being, of course, that simple projected images like this that just show a trace for each day are almost impossible for us to analyze as individuals. And so there's been this, if you like, industry over the course of the last 10 to 20 years looking at how we can take these data sets and use them more clinically effectively. And obviously the winner in that respect has been this projection called the ambulatory glucose profile, which simplifies those multiple lines into effectively 5 lines. Originally, those 5 lines would have been the median line, the interquartile range line, so the 25th and the 75th centile, and the 10th and the 90th centile. And I think for most of us in the classic AGP, that still remains the process. Although we have to also be aware, I guess, that with the Libre software, we're now looking at a slightly different profile, which is not the 10th and the 90th centile any longer, but is the 5th and the 95th centile, and more of that perhaps a bit later on. So my computer's frozen. No, it hasn't. There we go. So I think the key thing is that the AGP allows us to simplify these very complex data sets into things that we can use routinely and clinically in the clinic setting, because of course we have to take into account both the average glucose and the glucose variability as this part of process. And I think that idea of taking both the average and the glucose variability into account is really what's driven this concept of the so-called time in range concept. So this is an example of that, where we can see 3 individuals, all of whom have the same average glucose over a 24-hour period, but who, because of different variability across the scale, will spend a very different amount of time in this comfortable target range between 3.9 and 10 millimoles, or 70 and 180 milligrams per deciliter. And indeed, we can actually see that even though the average for this person is right in the middle of that range, they're actually spending more time high and low than they are in their comfortable range when the variability is high. So this time in range concept combines these two issues that we need to be looking at, and I think therefore has become a very straightforward process for us to start looking at in a very simplistic way. And perhaps not surprising from that perspective, we've now got a widely endorsed international consensus statement around time and range for the last 18 months or so. And I think the key thing from a UK perspective is that it's now being endorsed by all the major professional groups and patient groups for diabetes care in the UK. And of course, that this consensus is relevant for both people with type 1 and type 2 diabetes, is relevant to all glucose collection devices. So it isn't about which device someone is using, it's about all devices. And indeed, as our previous speaker Pratik has shown, that actually when people are moderately frequently using SMBG data 5 or more times a day, you can also use that the same concept of time in range to SMBG data, as well as you can to CGM data. And I think importantly for us in a clinic setting, whereas I think it's entirely inappropriate for us to ask people to say in a clinic, I think you should be trying to achieve a hemoglobin A1C of 6.5%, because nobody really knows what a hemoglobin A1C of 6.5% looks like on a day-to-day basis. The time in range is something we can use for target setting. Now, I personally wouldn't necessarily say, look, the goal here is to achieve a time in range of 70% to everybody. But I think if that we take where they are now, we can use the target setting to slowly increase that time in range. And so it also allows us, if we all use the same tool, to offer consistency in an individual's care if they're seeing different healthcare professionals over time. So the detail of those goals for the time in range is very similar for type 1 and, well, identical for type 1 and type 2 diabetes in terms of general population benefit. And the idea is to try and achieve at least 70% of time in this 3.9 to 10 range, and 4% less than 4% below 3.9. And although we call it a time in range goal, I think we have to, in our minds, expand that to time in range and time below range. I don't think it's about one or the other. Because of course there are those who may have specific risks relating to time below range, either because of frailty or because of comorbidity, or because of the fact that they have had episodes of severe hypoglycemia or reduced awareness of hypoglycemia. And for those high-risk individuals, I think the power here is that we don't need to change the target range. What we change is the percentage goals within those target ranges. So what we're looking at is, for the high-risk individuals, we want to see far less time in the low range. And as a result of that, we're prepared to accept less time in the target range. So, but again, it allows us to work this consistency over time. Now, one of the reasons I think this is a very powerful phenomenon, as we've seen, this is data from Libre, and a lot of my data will now come from Libre, being the commonest device out there. We know that people will look at the data with a sensor far more often than they would do finger stick tests, and that's perhaps understandable. But I think it's surprised many of the healthcare delivery population, so how much more often they will look at it. So the average we can see here is 14, 15 scans a day. And the reason for that, I think, is because people very quickly work out that the more scans they do, the better the effects they see, both in terms of time in range, in estimated hemoglobin A1C, and in hypoglycemia risk. But I think it's important for us to recognize this idea of projecting data as well, because we know that whilst these benefits from the point of view of reducing hypo risk can happen very quickly, the benefits in terms of reducing higher glucose levels happen much more slowly, and often will require healthcare intervention to try and help to advise around that. And so I think what we need to conclude from that is that to have a successful outcome, we both need to have a person with diabetes who understands their data and how to manipulate their therapies to improve that. But also we need to have periods where we've got, if you like, a third party making an objective, structured planning overview of that data. And of course, that's where the routine consultation here comes in. Because actually everybody using a Freestyle Libre, if they're using their phone to scan it, already has online data which can be assessed and used in a clinic. Interestingly, when I'm in clinic and talking to people for the first time, most of my patients don't know that they actually have that data online and available to be reviewed. And very few of them have ever done so themselves. And so I think that's really the power of the process, is us making sure that we do know we've got that data and start to use it routinely. Because of course, the majority of those people, the data will be on the cloud. There are multiple clouds, and obviously the one we've been talking about is this Libre View cloud. So the individual is using whatever the device they're using here on the right of the skull. That information is being pushed into the cloud, and from the cloud we can access it in our clinic computers very straightforwardly. You don't need to have your own account to do this at all. If the individual has got a login for Libre, then they've also got a login for Libre View. So you just go to the website and ask them what their login criteria are on their phone, and you can immediately see their data. However, it is much more powerful if you do have your own clinic set up for Libre View, because when you've done that, what you're then able to do is to say everybody who is chosen to share data with your clinic, you can then start to look at, so you can prioritize input and you can look in almost in real time at where individuals who are struggling may be, or individuals who are improving may be. And I think, although this is perhaps a little bit big brotherish for some of us to think about, I think it's been particularly over this last year and a half where clinical contact has often been much more difficult. This has been a really powerful tool. So I think the first absolute push is to say, try and make sure that you've got your own clinic login for LibreView, because without that, it's much more difficult for you to be able to easily assess what's going on with your patients. I think the next thing is to be able to say to be confident looking at people's data. And I'm going to spend my last 2 or 3 slides really looking at this process, because I think the time in range consensus has really pushed us towards this idea of the right of this slide, of saying what we want to be able to do is to look at some validatory metrics that include this time in range measure for all our patients. They want us to be able to look at these summative metrics, so that, as I said, the time in range and the averages and the amount of glucose variability that we can see. But then we also want to be able to look at the idea of the information over time of day and over days of the week. So this idea of using the ambulatory glucose profile and also using the individual day profiles. And all of those are available as a single report within the Libre data, which is what I think most of us start by looking at when we're using Libre data in clinic. So a couple of don'ts before I do some do's in this data analysis process. I think it's really important to recognize that there are some really what appear to be behaviors that would be okay, but actually I think are counterproductive rather than helpful. So an individual who has a high hemoglobin A1C does not necessarily need more insulin. So I don't think we should ever be really making insulin change advices based purely on the hemoglobin A1C. I think if you don't understand data, then don't guess. I think guessing with data is a very difficult process to justify. Even if you have a 50-50 rate, I don't think that's great consultation process. Most people have got more than one thing going on, but they've got one thing that is more important than the other things going on in terms of the things that are barriers to them achieving what they would like to. And I think that it's a mistake to try and fix all of the issues in one go. And what we should look to do is to try and fix the most important thing first and then take a second bite at it down the line, this idea of Kaizen approach to care. It's really important not to be the plumber. And I suspect Indian plumbers are the same as UK plumbers who arrive in your house and the first thing they do is they suck a big breath through their teeth and go, oh dear. We mustn't do that with glucose data because it's very difficult for people to take that on. And so I think we need to be aware of what we're trying to do. And then we take these reports in a structured state. We look at, first of all, at the time in range targets. If they're being met, my own personal practice is not to try and offer any specific additional advice at that point.
So that's 2 minutes, sorry.
Unless the person wishes to ask me something about a particular time in the day. If they're not achieving those or would like to make a difference, however, we then take the next 2 steps, which is first to look at the AGP. And when we look at the AGP, I'm tending to look at it saying, do I see predominantly a hypoglycemic risk, a hyperglycemic risk, or a variability risk on that profile? And then say, which of those things, therefore, is the one that's most important? And there's 2 ways of looking at that. One is to say, have an overall look and see what grabs your attention on the picture compared to an ideal. And then to be more systematic about it, looking through time blocks of the day, looking at all aspects of the care. Once we know that there is what the predominant issue is, we're then able to take that forward and discuss that with the patient, often using an individual day profile as an easier way of discussing a potential. And I think the key statement I would like to then say at the end is only make one change. If you make lots and lots of changes, it's very difficult for you to then work through what made the difference over time. So I'm aware this has been a real rush through this process, and I think 20 minutes is probably pushing it to try and achieve. But hopefully, it gives at least an idea. And I think this idea of it is actually very simple as long as you've set yourself up with the right tools and are prepared just to take a little bit of time to familiarize yourself with using those tools. Thank you very much.